A 67-year-old male presents with sudden onset severe headache, nausea, and neck stiffness. On examination, he is drowsy but responds to painful stimuli. His blood pressure is 200/110 mmHg, and a non-contrast CT scan of the head shows hyperdensity in the basal cisterns. What is the most likely diagnosis? A. Subarachnoid. Hemorrhage. B. Intracerebral hemorrhage. C. Ischemic stroke. D. Meningitis. E. Hypertensive encephalopathy. Correct answer is A. Subarachnoid hemorrhage. This patient's presentation is highly suggestive of a subarachnoid hemorrhage, SAH, a life-threatening neurological emergency. Key features supporting subarachnoid hemorrhage. Sudden severe headache. The thunderclap headache is a hallmark of SAH and is described as the worst headache of the patient's life. It typically reaches maximum intensity within seconds to minutes. Nausea and neck stiffness. These symptoms arise from meningeal irritation due to the presence of blood in the subarachnoid space. Imaging findings. A non-contrast CT scan reveals hyperdensity in the basal cisterns, which is diagnostic of SAH. The hyperdensity represents extravasated blood in the subarachnoid space. Hypertension. The elevated blood pressure, 200/110 mmHg, is often a response to increased intracranial pressure or may be a contributing factor to the hemorrhage, e.g., due to a ruptured aneurysm. Neurological status. The patient's drowsiness reflects a reduction in consciousness due to increased intracranial pressure or global cerebral ischemia from the hemorrhage. Common causes of SAH. Ruptured cerebral aneurysm, most common cause. Arteriovenous malformations. Trauma, less likely here due to no history of trauma. Why not the other options? B. Intracerebral hemorrhage. While intracerebral hemorrhage can cause severe headache and elevated blood pressure, it typically appears as a focal hyperdensity in the brain parenchyma on CT, not in the basal cisterns. It often causes focal neurological deficits, which are not described here. C. Ischemic stroke. Ischemic stroke usually presents with focal neurological deficits, e.g., weakness, aphasia, and does not cause hyperdensity on CT or neck stiffness. Headache is less common. D. Meningitis. Meningitis can cause headache, nausea, and neck stiffness, but it typically evolves more gradually. Fever is a hallmark symptom of meningitis, and CT imaging would not show hyperdensity in the basal cisterns. E. Hypertensive encephalopathy. Hypertensive encephalopathy presents with diffuse headache, confusion, and visual disturbances due to severe hypertension. It does not cause hyperdensity on CT or sudden, severe symptoms like SAH. Key learning points. Subarachnoid hemorrhage, SAH, should be suspected in patients with sudden onset severe headache, meningeal signs, e.g., neck stiffness, and hyperdensity in the basal cisterns on CT scan. Non-contrast CT is the initial imaging modality of choice for suspected SAH, with sensitivity highest within the first 6 hours of symptom onset. If the CT scan is normal but SAH is still suspected, a lumbar puncture may reveal xanthochromia, yellow CSF due to bilirubin from blood breakdown. Management overview. Stabilization. Airway protection and control of blood pressure, target systolic BP less than 140 mm of mercury. Definitive diagnosis. CT angiography to identify the source of bleeding, e.g., aneurysm. Definitive treatment. Surgical clipping or endovascular coiling for ruptured aneurysms. Supportive care. Monitor for complications like vasospasm, hydrocephalus, and rebleeding.